Hello, everyone. My name is Suzanne Jimenez, and with my partner Monique Shavers, we will be presenting you an evaluation of natural therapies specifically for two very known diseases within the musculoskeletal disorder categories, which are osteoarthritis and fibromyalgia. We hope this presentation provides valuable information of the trending therapies used to treat these chronic diseases and hopefully serves as a guide for educating patients affected by them. Without further ado, grab your popcorn, sit back, relax, and enjoy this almost 1 hour long presentation. Alright, so let's start off with some general information about the musculoskeletal system. So the musculoskeletal system comprises of the bones, muscles, joints, tendons, ligaments, and cartilage. There are more than 150 diagnoses related to this disease category, and it is considered the second largest contributor to disability worldwide, low back pain being the single leading cause of disability globally. The most common and disabling musculoskeletal conditions are osteoarthritis, back and neck pain, fractures associated with bone fragility, injuries, and systemic inflammatory conditions such as rheumatoid arthritis. Musculoskeletal conditions significantly limit mobility and dexterity, leading to early retirement from work, reduced accumulated wealth, and reduced ability to participate in social roles. This image was taken from the third edition of the Executive Summary of the Burden of Musculoskeletal Diseases in the U.S., which clearly describes the direct and indirect costs of the musculoskeletal disorders in the U.S. The numbers are astonishing, and this is just one of the diseases, or one category of diseases, I should say. The cost of treating major musculoskeletal diseases, which often includes long-term pain and disability, is greater than for treatment of many other common health conditions. Yet, an interesting fact is that research dollars to identify causes, create new treatments, and reduce pain and disability remain much lower than that for other health conditions. So for the purpose of this presentation, I would like to focus on direct and indirect costs. For the year 2011, it was totaled at $213 billion, or 1.4% of the U.S. gross domestic product, which is defined as the value of goods produced and services provided in a country during 1 year. Treatment costs, which were calculated also at $796 billion, you can also see on the image, and in 2012, 1 in 2 Americans was diagnosed with MD, and 25.5 million people lost an average of 11.4 days of work due to back or neck pain. Musculoskeletal disorders affect people of all ages, although their prevalence increases with the wear and tear of age. For this section of the presentation, I will be focusing on osteoarthritis, which we already learned was one of the most common and disabling conditions within this category. So let's get started. Osteoarthritis, sometimes called a degenerative joint disease or degenerative arthritis, is the most common chronic condition of the joints by damaging the slippery tissue that covers the ends of bones in a joint. The worn away cartilage would eventually expose the bone and allow them to rub against each other. This causes spurs to grow out from the edges of the bones and synovial fluid increases. It is most common in people over 65 years old, and its determinants are increasing age, obesity, previous joint injury, weak muscles, and genetics. As you can see in the infographic by the CDC, in 2013, the national arthritis attributable medical costs were $140 billion, half of that due to ambulatory medical care. It is also among the most expensive conditions to treat when joint replacement surgery is required. Signs and symptoms of OA tend to build over time and depend on localization and severity of the breakdown. The most common symptoms are stiffness, particularly after resting, limited range of motion, clicking or cracking sound when a joint bends, mild swelling, and pain. Those are general signs and symptoms, but in the slide you can see that depending on the localization of the disease, different signs and symptoms can reflect. For example, on the hips, the pain is in the groin area or buttocks. On the knees, there's grating or scraping sensation. On fingers, spurs at the edge of the joints can form. And on feet, pain and tenderness and some swelling in ankles or toes is visible. Now, Different people can have different pain tolerances. It's important to note that the severity of the condition is not only determined by the amount of pain a person is enduring, but also from radiographic imaging. On the next slide, you'll see what I mean. I was granted permission to use this radiography for the purpose of this presentation. It was taken 2 years ago, and this particular patient is a premenopausal female. She eventually had double knee replacement surgery after enduring several years of what she referred to as, and I quote, discomfort but not pain. Yeah, right, she was definitely in pain. Persistent pain, actually. Minimal mobility, sleepless nights, and high dependence on NSAIDs. Standing views show a near obliteration to the lateral tibiofemoral joint compartment, which basically means that the bones are nearly touching each other. And you can clearly see that by looking at the side of the left knee right there. She describes this phase of her condition as very uncomfortable. Her knees were very stiff, especially after long periods of rest or sitting down. Her mobility was very limited due to pain on the side of her knee, and scraping and grating sensations were present. She would usually take NSAIDs when she knew she needed to move a lot that day, like go grocery shopping, for example, or cleaning the house. So what is the pathophysiology of the disease? Well, under normal conditions, the matrix is subjected to a balanced dynamic remodeling process of the degradative and synthetic enzymes. This way, the volume of cartilage is maintained. In OA, there is an overexpression of degenerative enzymes that results in the loss of collagen and proteoglycans. Chondrocytes activate to synthesize enhanced amounts of proteoglycans and collagen to mitigate loss. However, with the progression of the disease, reparative attempts are outmatched. Primary enzymes responsible for degradation of cartilage is matrix metalloproteinase, or MMPs, which are divided into 3 general categories as shown above. One possible candidate for the activation of these enzymes is interleukin-1, a potent pro-inflammatory cytokine that in vitro is capable of inducing chondrocytes and synovial cells to synthesize MMPs. Reminding that osteoarthritis is a chronic long-term disease, so there's no cure, but treatments are available to manage symptoms. Current conventional therapies for OA include analgesics for pain, non-steroidal anti-inflammatory drugs to ease inflammation and related pain. Corticosteroids are a powerful anti-inflammatory drug that can be taken orally or by injecting directly into the joint. And hyaluronic acid, which is a naturally occurring joint lubricant and shock absorber of the body. Many people with OA use natural or alternative therapies to address symptoms and improve their overall well-being. These include nutritional supplements, acupuncture or acupressure, massage, relaxation techniques, and hydrotherapy, among others. Just as well, there are other therapies that can be applied to help manage pain and mobility. These include physical activity, stretching, weight management, physical and occupational therapy, and assistive devices. From this slide forward, we're going to be talking about the 2 natural product therapies mostly used to treat osteoarthritis. This first one is glucosamine sulfate and chondroitin sulfate. They are the chemical forms most used in the treatment of arthritis. They are used as supplements to treat pain and loss of function associated with the condition. Chondroitin is a component of connective tissue in humans found in cartilage and bone. It can be manufactured from the cartilage of animals like cows, pigs, or sharks, or it can be made in the lab. Glucosamine is also a major component of joint cartilage. It's an amino sugar produced naturally in humans and usually harvested from shells of shellfish or made in the lab. Several different forms of glucosamine are sold as supplements, and even though they have some similarities, they can react differently in the body. Chondroitin sulfate stimulates collagen synthesis, while glucosamine inhibits prostaglandin release. How is it traditionally used? In many European countries, it is approved as a prescription medication to treat OA, but in the US, it is often combined with glucosamine supplement. Even though it has been extensively researched, including the most comprehensive long-term study of any supplement, which is the glucosamine chondroitin arthritis intervention trial, it still reveals conflicting results. Now I'm going to talk about three different studies showing the effects or efficacy of glucosamine and chondroitin. Now, the present study reports the first randomized controlled trial in the efficacy of three different formulations of combined glucosamine and chondroitin in knee OA pain. Group 1 and 2 received 500 milligrams of glucosamine sulfate with 400 milligrams of chondroitin sulfate as capsules 3 times daily or sachet preparation once daily, respectively. Group 3 received 500 milligrams of glucosamine hydrochloride with 400 milligrams of chondroitin sulfate capsules 3 times daily. By week 16, there were significant pain reduction and reduced Lukens index values for all groups. We're going to mention the Lukens index values on some of the other studies, so let me tell you what it measures. So it's basically a questionnaire used to assess the severity of OA of the knee. The higher the index score, the higher the handicap. Monthly assessed secondary outcomes, specifically pain assessment and Lukens index, as well as patient and physician global assessment of disease activity significantly improved for all groups. As the largest study reporting the efficacy of three different formulations of combined glucosamine sulfate or glucosamine hydrochloride with chondroitin sulfate in patients with knee OA, it has provided data showing that these compounds are non-inferior with regard to efficacy in relieving OA symptoms and are equally similar in regarding safety. All three groups had a significant pain reduction result, and all secondary outcomes improved as well for all three groups. This second study is said that it is the first randomized controlled trial sponsored by a pharmaceutical company to evaluate the efficacy of the combination of chondroitin sulfate plus glucosamine sulfate for the treatment of knee OA, and the first to include a data and safety monitoring board to ensure bias-free study. Primary efficacy endpoint was the mean reduction from baseline to end of study in the global pain score on a visual analog scale, or VAS. The secondary efficacy outcomes comprised of the mean reduction in the Total Western Ontario and McMaster University's Osteoarthritis Index, or WOMAC index, as well as the pain and function subscale scores, the investigator's global assessment of disease activity, percentage of treatment responders according to the outcome measures in Rheumatology and Osteoarthritis Research Society International, response criteria, and the use of rescue medication. That's a lot. At the interim time point, where 50% of the total sample had completed the first part of the study, in the modified intent to treat population, combination therapy of glucosamine sulfate and chondroitin sulfate was inferior to placebo in reduction of joint pain, and no between-group differences were seen in the per-protocol completers. Both placebo and treatment groups improved to a similar extent to the WOMAC scores, as well as the pain and function subscale scores of the WOMAC index. No difference was seen between groups for the frequency use of rescue medication. In this third study, different from the first two, we are comparing a natural therapy with a conventional therapy, which is celecoxib, a popular nonsteroidal anti-inflammatory drug. Primary outcome is the mean decrease in WOMAC pain subscales from baseline to 6 months. Secondary outcomes are stiffness and function subscales of WOMAC, VAS for pain, OMERACT ORC responder index, presence of joint swelling and effusion, use of rescue medication, investigators and patients' global assessment of disease activity and response to therapy, and health status. The major conclusion of this trial indicates that a combination of glucosamine hydrochloride with chondroitin sulfate has comparable efficacy to celecoxib, which is a nonsteroidal anti-inflammatory drug, as I mentioned before, in reducing pain, stiffness, functional limitation, and joint swelling effusion after 6 months in patients with knee osteoarthritis, with a good safety profile even for those with cardiovascular or gastrointestinal conditions. Results also confirm that the combination of glucosamine hydrochloride with chondroitin sulfate proves to be non-inferior to celecoxib in reducing pain. So overall evaluation of therapy for glucosamine and chondroitin used to treat osteoarthritis suggests that there is some beneficial effects of each of the treatments discussed, but not in a significant way. Study periods were too short to clinically prove the efficacy of each treatment discussed, or study samples were too small to determine a generalized conclusion. It would seem that the combination of glucosamine sulfate with chondroitin sulfate would have better results since sulfate is needed for cartilage formation, but study results are still inconclusive. The glucosamine chondroitin arthritis intervention trial was a large randomized placebo-controlled trial conducted at several sites across the U.S. It was founded by the National Centers for Complementary and Alternative Medicine and the National Institute of Arthritis and Musculoskeletal and Skin Diseases. The results of the primary study showed that the combination of glucosamine chondroitin sulfate did not provide significant relief from osteoarthritis pain among all participants, and the secondary study showed that glucosamine chondroitin sulfate together or alone appeared to fare no better than placebo in showing loss of cartilage and knee osteoarthritis. Now let's talk about another popular alternative medicine to treat osteoarthritis, which is MSM. Now, MSM is a naturally occurring sulfur in fruits, vegetables, grains, humans, and animals, and claims suggest that it helps reduce pain and inflammation. It also seems to act as an analgesic by lessening nerve impulses that transmit pain. Sulfur is needed to form connective tissue. That's why studies suggest that glucosamine sulfate is a better alternative than glucosamine hydrochloride. In arthritis and inflammation, it is used alone or in combination, usually with glucosamine, chondroitin sulfate, and boswellic acid. Study suggests it exerts an anti-inflammatory effect through the reduction in cytokine expression. In vitro studies suggest that MSM protects cartilage through its suppressive effect on interleukin-1 and tumor necrosis factor. The first study I'm going to talk about regarding MSM is a 12-week randomized double-blind placebo-controlled trial where participants were assigned to a MSM group receiving 1.125 grams 3 times daily or a placebo group. Patients had to have symptomatic OA for at least 6 months and radiographic confirmation of disease. Primary outcomes for this study were WOMAC questionnaire, aggregated locomotor function score, SF-35 health survey score, and the VAS for pain. The aggregated locomotor function score is a new measure that hasn't been discussed in any of the prior studies. It is basically a sum of the mean timed scores in seconds on 3 locomotor functions, which are walking 8 meters, ascend and descend 7 stairs, and transfer from a sitting to a standing position. The SF-35 is a health questionnaire on pain and quality of life. The second outcomes were the Knee Society Clinical Rating System scores, which are divided into knee score and function score. The major results of this study are that patients with OA of the knee treated with the protocol amount of MSM for 12 weeks show a significant improvement in function and total WOMAC scores and visual analog scale for pain compared to the control group. However, pain and stiffness subscales of the WOMAC index were no different between the groups, as well as other outcome measures. In conclusion, due to some similarities and some differences with other studies with a similar methodology, patients with knee OA taking MSM for 12 weeks showed improvements in pain and physical function. However, they are small improvements and yet to be determined if they have clinical significance. This other study is a double-blind, randomized, controlled clinical trial with the purpose of comparing the clinical outcomes of glucosamine chondroitin sulfate with glucosamine chondroitin sulfate plus MSM. I found this article interesting since it used MSM in combination with another known supplement to evaluate efficacy. Subjects were allocated by permuted block randomization to either the GCS group or the GCS plus MSM group, or the placebo group. Comparing between groups, GC plus MSM treatment showed significant WOMAC score changes compared to placebo. In pain perception, the difference was statistically significant at week 12 for the GC plus MSM group compared to the placebo group. It's important to note that these combination drugs are slow-acting and thus tend to present significant differences later in the study rather than sooner. In contrast with glucosamine chondroitin sulfate, findings suggest that it was not effective in reducing joint pain in OA compared to placebo. The third and last study is a prospective randomized controlled trial where participants affected by knee osteoarthritis were randomly assigned to a treatment group, which was the MSM with boswellic acid group, or a control group, which was the glucosamine sulfate group. At 2 and 6 months, the efficacy of both nutraceuticals was assessed using the VAS scale and Lukens index for joint function along with the use of anti-inflammatory drugs. Both groups at follow-ups showed decreased pain severity with better value for the MSM and boswellic acid group. The Lukens index total was significantly reduced in both groups, but especially in the treatment group. For the secondary outcomes, taking anti-inflammatory drugs was reduced at follow-ups with a tendency to better results with the MSM and boswellic acid groups. So this study suggests the potential benefits of MSM and boswellic acid in knee OA patients in pain management and functional recovery, and the reduction in dependency of NSAIDs, though further research to clarify long-term effects is necessary. Overall evaluation of MSM shows that the combination of MSM with boswellic acid showed promising benefits in the management and treatment of knee OA. However, more long-term research is necessary. Overall, MSM as a combination therapy with another nutraceutical seems to be more beneficial than MSM alone in the management of knee OA. Studies do suggest that a 500 milligram capsule daily is a good insurance for most people, and overall it seems MSM is a safe alternative as a short-term treatment for pain and physical function. However, long-term effects should be studied. The following are general recommendations if considering any of the two alternative therapies or any other alternative therapy to treat osteoarthritis. For the use of combination glucosamine chondroitin, the suggested dose would be 2,700 milligrams daily of glucosamine hydrochloride or sulfate with chondroitin sulfate. Studies suggest that a 500 milligram capsule daily is a good insurance for most people taking MSM. If taking or considering taking dietary supplements for osteoarthritis, it's important to tell a healthcare provider to prevent any unnecessary adverse reactions. The following are other alternative therapies used to treat osteoarthritis or other musculoskeletal diseases. These are platelet-rich plasma therapy, or PRP, which attempts to take advantage of the blood's natural healing properties to repair damaged cartilage, tendons, ligaments, muscles, or even bone. S-adenosyl L-methionine, or SAMe, which is a compound found naturally in the body. SAMe helps produce and regulate hormones and maintain cell membranes. Avocado soybean unsaponifiables, originally a natural vegetable extract made from 1/3 avocado oil and 2/3 soybean oil, and some studies suggest that it blocks pro-inflammatory chemicals. Prolotherapy, which is an injection of an irritant solution, often dextrose, to stimulate a mild inflammation which tricks the body into thinking the area is injured and to begin healing again. As you can see, the wide array of possible therapies suggests that a lot more studies need to be made in order to define an effective treatment for osteoarthritis. Keep in mind that these studies might have better results in treating other types of arthritis or osteoarthritis in other parts of the body. In addition to the therapies mentioned, it is also important to address that overall lifestyle change and nutrition can be beneficial in treating osteoarthritis symptoms and musculoskeletal diseases in general. Thank you very much for your attention to this half of the presentation. Now I will leave you with Monique, who will be taking us through the musculoskeletal condition of fibromyalgia. Thank you.
Hello everyone, my name is Monique Chavers and I will be presenting fibromyalgia. But what is fibromyalgia? Fibromyalgia is a common neurologic health problem that causes pain all over the body. Particularly, there is tenderness to touch, pressure, affecting muscles and sometimes joints or even the skin. As you can see in the pictures above, there are trigger points that are located around the neck area, the hips, the knees, and the elbows. These are our joint areas and our pain trigger points. When doing research about fibromyalgia, it is categorized under arthritic conditions. So oftentimes when we're looking for remedies or therapies, you can also look for remedies and therapies under arthritic conditions. Okay, here we're going to dive into the signs and symptoms of fibromyalgia. In no particular order, this flowchart just displays some of the signs and symptoms that individuals display when they're presented with fibromyalgia. So some of the signs, again, tenderness to touch or pressure affecting muscles, joints, and even the skin. Severe fatigue, sleep problems. People are waking up unrefreshed. There are problems with memory or thinking clearly. Some symptoms are depression or anxiety, migraines or tension headaches. People also display digestive problems or irritable bowel syndrome or gastroesophageal reflux disease, often known as GERD or GERD. Irritable or overactive bladder, pelvic pain, again, those joints display pain in the trigger point areas, and temporal mandibular disorder, often called TMJ, which is a symptom called, you may know it as lockjaw or joint pain or ringing in the ears. Right here, we're going to explore how fibromyalgia affects individuals within the United States. I have a chart here that was adopted by the CDC. It does display arthritis. Again, I told you before, arthritis is, or fibromyalgia is under the umbrella term of arthritis. So here the chart displays that back in 2004, about 46 million people were diagnosed with arthritis, and it is projected that by 2040, 78 million individuals will be diagnosed with arthritis. So to date, fibromyalgia affects about 4 million U.S. adults, so that's 2% of the adult population. It can affect individuals of all ages, including children, but is most commonly found in women. Most are diagnosed during their middle age, and is also found in individuals with lupus, osteoarthritis, rheumatoid arthritis. And back to the women, it is a weaker association that needs further research. So women are twice as likely to have fibromyalgia than men. This can be due to stressful or traumatic events such as car accidents, post-traumatic stress disorder, repetitive injuries, or injuries from repetitive stress on a joint, such as frequent knee bending. So illnesses such as viral infections can also cause fibromyalgia, family history, and obesity. So again, it needs to be further research done as to why women are twice as likely to have fibromyalgia and be affected by it. But that's how we're going to dive further into it as we continue to do our research. The pathophysiology of fibromyalgia involves other factors, or a number of factors, which includes abnormalities in neuroendocrine and autonomic nervous systems, genetic factors, psychosocial variables, and environmental stressors. These factors play a role along with other fibromyalgia characteristics that display persistent or recurrent pain and emotional distress, such as IBS or TMD, or temporomandibular disorder, or lockjaw. So in the picture depicted to the right, starting at A, it shows an acute pain stimuli. So these are pain pathways. So A displays acute pain. So painful stimuli is transmitted from the periphery to the dorsal horn via afferent fibers. So the dorsal horn then takes the stimuli to the brain via the spinal thalamic tract. The pain activation occurs via descending inhibitory pathways, which releases neurotransmitters, norepinephrine, serotonin, substance P, and other endorphins. So in B, we shift over to B, and it is a normal pain processing. So the dorsal horn sends the pain to the afferent signals, and then it releases substance P, which is an excitatory amino acids, binds to the pain transmitters and neurons, which that's a normal pathway and it's acute, so then it subsides. Whereas in C, the pain or the neurons of intense or prolonged exposure to painful stimuli increase afferent signals and releases the substance P and excitatory amino acids. Therefore, there's an influx in calcium and an increase in nitric oxide, which brings me to the altered neurotransmitters. This process lowers the pain threshold. So as substance P increases, it lowers the pain threshold, which amplifies a normal sensory signal. So a person in a normal healthy individual, if you rub up against their hand, it's nothing to them. There's no pain with that. But unlike a normal healthy individual, the individual displayed with fibromyalgia or that presents with fibromyalgia, that simple rubbing up against the hand may excite them and put them in immense pain because those normal signals are so amplified, which also leads me to the mood disorders. So the hypothalamic pituitary axis is a critical component of the stress adaptation response. So in fibromyalgia, stress adaptation response is disturbed, leading to stress-induced symptoms. So psychiatric comorbidity has been associated with fibromyalgia. However, this needs to be identified during consultation process, which requires special consideration. So that requires, of course, a psychiatrist, and that'll be outside of our scope of practice. So you probably have to refer if you see someone with fibromyalgia. Because individuals with fibromyalgia may present with many different ailments and things that are bothering them, there are plenty of treatments and medications and therapies that one could choose from based on what their patient or client needs. So for medications, we have the central nervous system agents. Our pain is sent to the central nervous system, and therefore it can trigger us to tell us it hurts or it doesn't. So we have agents for that. Also for the mood disorders, we have antidepressants, muscle relaxants, anticonvulsants, and NSAIDs, which are over the counter. So the muscle relaxants, of course, they reduce muscle tension and help relieve muscle pain and discomfort. The NSAIDs, or the non-steroidal anti-inflammatory drugs, relieves that pain and decreases inflammation, also reduces fever. So we have specialists that also help with the treatment of fibromyalgia. We have rheumatologists, which specializes in arthritis and other rheumatic diseases. You have a clinical psychologist, which treats the mental and mood disorders. So it's primarily just talk therapy. Then you have physical medicine and rehabilitation, which restores the function and quality of life to those with physical disabilities in conjunction with the physical therapist. So then we have the self-care techniques, which is physical activity, stress management, and other relaxation techniques. You can take up yoga, walking, anything low impact that will help the person to relax and actually manage fibromyalgia and their pain. Here I would like to introduce the first natural product therapy, vitamin D, which is used as a natural product to reduce musculoskeletal pain. Vitamin D is also responsible for physical and psychological therapeutic benefits. It also plays a role in the equilibrium of calcium and phosphate, which are also a part of the... So now I'm going to touch base on one of the two natural product therapies. Here I have vitamin D. Our report showed that vitamin D deficiency is related to musculoskeletal disturbances. So therefore, vitamin D is used to naturally reduce musculoskeletal pain. Vitamin D also assists with physical and psychological therapeutic benefits. It is also a contributor to the equilibrium of calcium and phosphate, and also plays an important role in bone health. Often, vitamin D is taken orally in a capsule form. However, it can be consumed within a diet in fortified juices and milk, and also can be obtained from natural sun. Okay, now we're going to dive into several studies that involves vitamin D on quality of life and pain management. So this study now in front of us in particular studied the effects of vitamin D optimization on quality of life in patients with fibromyalgia. It was a randomized double-blind study that used a placebo in a controlled trial. It used trazodone and vitamin D together to determine if these vitamins and substances together would improve on the quality of life of patients. This was conducted in an academic medical center in Iran. Diagnostic criteria or inclusion criteria was adopted from the American College of Rheumatology, and it was used to confirm diagnosis of fibromyalgia and to determine the serum levels of each individual. So to determine the serum levels of vitamin D in individuals, it was measured with the commercial immune diagnostic system. Widespread pain index was also conducted to determine how far spread out the pain was in each individual subject. The fibromyalgia impact questionnaire also was used to determine how the individual felt during or how their fibromyalgia had affected them and their quality of life. So major results, significant improvements were seen in the widespread pain index and in the fibromyalgia impact questionnaire. In the vitamin D group and the vitamin D and trazodone supplementation together improved pain management in the subjects. In this particular study, efficacy of vitamin D supplementation was used to determine the quality of life and pain management in individuals with fibromyalgia. Also, the individuals in this study were presented with vitamin D deficiency. So they used a pre and post test treatment to evaluate vitamin D treatment over the course of 3 months if subjects were meeting inclusion criteria. 50,000 IUs per week via oral vitamin D3 for 3 months were given to patients. This study was conducted in a physical therapy in a rehabilitation clinic in Turkey. So the inclusion criteria included patients with non-specific chronic widespread pain, fibromyalgia, and vitamin D deficiency. So those individuals who participated needed to have a vitamin D deficiency. So outcome measurements, severity of pain visual analog scale was used. The Beck Depression Inventory questionnaire was used. A quality of life scale, which was a short form, was used. A tender point count, where the researchers went in and counted how many tender points each individual had. So severity of waking, unrefreshed, headache, tenderness on tibia. Also meeting the criteria of fibromyalgia and level of pain satisfaction were some of the outcome measurements used to determine if vitamin D supplementation actually had an effect on quality of life, widespread pain, and vitamin deficiency. So some major results. There was a decrease in visual analog scale pain, the anesthesia, severity of waking unrefreshed, tender point count, and I believe the Beck Depression Inventory all decreased. So vitamin D replacement treatment in patients with non-specific chronic widespread pain provided improvements in musculoskeletal systems. The level of depression and quality of life in the patients also improved. So in this final study of vitamin D efficacy and the safety of vitamin D, this study actually evaluated both of those variables in women diagnosed with fibromyalgia. This was a clinical trial, so therefore it was interventional, randomized, double-blind, placebo-controlled trial. It was located in Mexico, and inclusion criteria were female patients older than 18 years of age, patients who agreed to participate in the study, and those who met the ACR criteria from 1990 and the 2010 criteria for fibromyalgia. They had to have no previous use of vitamin D, and patients also had to be diagnosed with primary or secondary fibromyalgia. So some outcome measurements, decreased fibromyalgia impact questionnaire was used, and the score was used. So, and then also a decrease in visual analog scale was used. So much like the other studies, these scales continue to be used throughout, which I believe improves the efficacy and the reliability and validity of these outcome measures. So because this was a clinical trial, there were no actual results, but the goal was to achieve 20% decrease in baseline fibromyalgia impact questionnaire scores. And it also wanted to achieve a 20% decrease in baseline visual analog scale scores. So that was the goal of this clinical trial. I have to go back and follow through to determine if or when these results get back, how it actually did perform in the evaluation of efficacy and safety of vitamin D in women diagnosed with fibromyalgia. So some key takeaways to take from the vitamin D therapies. So on average, vitamin D supplementation of about 1,000 to 4,000 IUs per serving or 50,000 IUs per week were used in the studies. Vitamin D supplementation was shown to have significant improvements in pain reduction, improved quality of life, and depression. Within the studies, there were no adverse effects that were among the subjects, so no one had any limitations or adverse effects from taking such high doses of vitamin D. However, additional findings suggest that further research is needed to determine if these therapies can reduce overall pain, depressive symptoms, and quality of life in other various populations. So I took it further to look at the regular recommended dietary allowances for vitamin D. So from age 0 through 70, for females and males, it's about 400 IUs to 800 IUs per day is the recommended daily value. And other research saw that vitamin D in children 9 years and older, adults, pregnant, and breastfeeding women who take more than 4,000 IUs a day of vitamin D may experience the following adverse effects, which is nausea, vomiting, poor appetite, constipation, weakness, weight loss, confusion, disorientation, heart rhythm problems, and kidney damage. So these factors were not included in the studies, but it is something to keep in mind looking into studies that use such high values of supplementation of vitamin D. So for my second therapy, I researched as acetyl L-carnitine, which is effective in improving depressive symptoms, neuropathic pain release. It improves quality of life, and it can be taken orally or intramuscularly. So what this is an amino acid that has functions involved in metabolism of food into energy. The acetyl group is a part of acetyl L-carnitine, contributes to the production of neurotransmitter acetylcholine, which is required for mental function. So acetyl L-carnitine, or ALC for short, has numerous functions in energy metabolism, such as facilitating uptake of acetyl-CoA into the mitochondria during fatty acid oxidation. It enhances acetylcholine production, stimulates protein and membrane phospholipid synthesis, and prevents excessive neural cell death. It also can be used for not only fibromyalgia, but other age-related cognitive declines, such as Alzheimer's. It can help with neuropathy, peripheral neuropathy, so pain in the hands and in the feet. It also helps with depression. It's been used for Down syndrome, erectile dysfunction, liver cirrhosis, macular degeneration, type 1 diabetes, and type 2 diabetes neuropathy, and amenorrhea, male infertility. So this natural therapy is widely used, and it can also be consumed not only in the capsule or intramuscularly, which is also intramuscularly. They can inject it directly into the muscle to relieve the tension in the muscle and things of that nature. So back to obtaining the ALC in the diet. It can be consumed in beef, chicken, milk, and cheese. So in about 4 ounces of beef or chicken cooked, you can obtain this natural substance. So in beef, you can get about 56 to 162 milligrams. In 4 ounce cooked chicken is 3 to 5 milligrams, and 1 cup of whole milk is 8 milligrams. In cheese, about 2 ounce cheddar is about 2 milligrams. So this drug has been approved by the Food and Drug Administration to treat primary and certain secondary carnitine deficiency syndromes, because if people such as like vegans and things of that nature, or anyone who excludes certain food groups out of their diet are or does present with a deficiency, it has been approved through the FDA to treat those conditions of the carnitine deficiency. So here in this first study, it was a randomized controlled trial comparing duloxetine and acetyl L-carnitine in fibromyalgia patients. So with preliminary data. So in this randomized controlled study, fibromyalgia patients received duloxetine, that's about 60 milligrams per day, or acetyl L-carnitine, about 1,500 milligrams per day. So drug efficacy was assessed at a baseline, again at 4 weeks and 12 weeks. This study was located in Italy, and the inclusion criteria for this group, it had to be females between the ages of 18 and 65. They also had to present with fibromyalgia syndrome, and then a pain intensity visual analog scale was included in this criteria. So they had to have a certain number on that pain intensity visuals analog scale in order to participate in this study. So some of the outcome measures, they had the MADRS questionnaire, which is the Montgomery-Åsberg Depression Scale. It was a clinician-administered questionnaire designed to assess severity of depression. So the scores range from 0 to 60. Higher scores reflected of more severe symptoms of depression. And then they had the HADS, or the Hospital Anxiety and Depression Scale, which was divided into depression and anxiety subscales, each of which ranged from 0 to 21. So a score of greater than 8 suggested that a clinically relevant level of depression or anxiety was present. And then they used the current pain intensity scale, which also was measured using the device, whose scores range from 0, no pain, to 10, being extreme pain. So this here also measured the pain of the subjects. And then lastly, we had the SF-36 health status evaluation. It included 8 health status domains whose scores range from 1 to 100. The higher scores indicating a better health. So the major results of this study: general clinical improvement. They had positive effects on pain, depressive symptoms, physical components of quality of life, and fibromyalgia syndrome. So overall, the outcomes had improved in their fibromyalgia patients. So here in this second study, it was a double-blind, multi-center trial comparing acetyl L-carnitine with a placebo in the treatment of fibromyalgia patients. So in this randomized clinical trial, 500 milligrams of the acetyl L-carnitine was used, or the placebo, via intramuscular injection. This study was conducted in Italy. Inclusion criteria: the patients or subjects had to be at least 18 years of age and had to have met the American College of Rheumatology criteria of 1990 for fibromyalgia. So the outcome measurements: the pressure threshold meter, which was a rubber disc of about 1 centimeter, was applied at 90-degree vertical angle to the 18 tender point sites on each individual. And then a visual analog scale was again used in this study. It was used to evaluate the self-perceived stiffness, fatigue, tiredness on awakening, asleep, work status, depression, and musculoskeletal any musculoskeletal issues that they may present with, or musculoskeletal pain, And then again, we had the short form 36, so that's the SF36 questionnaire, and the typical 9 domain calculated separately. The Hamilton scale was also used for assessing depression. So the major results in this study: a number of tender points in total myalgic scores decreased. So the acetyl L-carnitine group continued to improve. The visual analog scale score significantly improved. And then there was overall improvement in pain and general and mental health seen in subjects upon completing this study. And for my final study, it was a clinical trial. So this was a clinical study on acetyl L-carnitine. It was a multi-center randomized, double-blind, placebo-controlled, and parallel clinical trial in which the location had not been disclosed. Patients had to sign the informed consent form. They could have been male or female, ages 18 to 75 years old. They had to have been treated with taxoids, stropatlin, visicrencin, the peripheral sensory neuropathy grading after chemotherapy. So basically, they had to present with some kind of chemotherapy grade 3 or grade 2, lasting for at least 1 month. So these patients were already in, so I had a precursor prior to receiving the acetyl L-carnitine. So some outcome measures, they wanted to see changes in the peripheral sensory neuropathy grades, changes in the neuroelectrophysiological test, changes in the cancer-related fatigue level. So again, they had to have cancer a grade level 3 or grade 2 for at least 1 month. And then they also wanted to see changes in physical condition score. So like the previous clinical trial, when I went over the vitamin D, these were not actual results. These are projected results. This is what the researchers will hope for upon obtaining results. So they would like to see changes in peripheral sensory neuropathy grades after 8 weeks of treatment. They also would like to see changes in neuroelectrical physiological tests after the 8 weeks in either the ALC or placebo treatments. They will also like to see changes in cancer-related fatigue levels after the 8 weeks of treatment. And finally, they would like to see changes in physical condition scores after the 8 weeks of treatment. So at least one of the neuroelectrophysiological examination results were abnormal. So physical condition score was greater than 60 and the anticipated lifetime was greater than 60. So overall, acetyl L-carnitine supplementation showed significant improvements in pain reduction, quality of life, and depressive symptoms. There were no adverse effects in the research studies. None of the subjects displayed any adverse effects upon taking this supplement. And then it was recommended on average about 500 milligrams or 2 capsules a day was provided ample supplementation for benefits. However, further research is needed again to determine if these therapies can reduce overall pain, depressive symptoms, and quality of life. So upon diving into all the research findings and what the supplements can do and how they're beneficial, my recommendations for patients with chronic widespread pain would be to be investigated for vitamin D deficiency. I will also recommend that they look into the vitamin D daily recommendation to see if the vitamin D level, the upper intake level, is tolerable for the person, because the tolerable intake for vitamin D is about 2,000 IUs, whereas the researchers use between 1,000 and 4,000 IUs per serving. So I also believe that further research should be conducted to determine RDIs for vitamin D in individuals with fibromyalgia. So they may need just a little bit more if they do display any deficiencies. Also, dosage of acetyl L-carnitine has not been established, so there are no RDIs or RDAs or daily recommended intakes, and that should be established because because we can get it naturally through our diet. It should be determined whether or not supplementation is even needed, or how much supplementation is needed per day. So at doses of about 3 grams per day, carnitine supplements can cause nausea, vomiting, abdominal cramps, diarrhea, and fishy body odor. So again, those dosages should be set per day, or what we should have or what the people should not have. On the rare side of effects, it includes muscle weakness, uremic patients, and seizures in those with seizures disorders. So based on the National Institution of Health findings, doses of acetyl L-carnitine has not been established. So therefore, my recommendations not only for patients but for the overall nutrition and food and drug community is to make sure that these daily dosages of vitamins, be it natural or through regular diet intake, be established so that we can ensure the safety of people who are consuming these supplements. And finally, we have the alternative therapies of fibromyalgia, which includes Chinese herbal medication, Chinese herbal tea, acupuncture, and Tai Chi. Of the four of these alternative therapies, acupuncture is of the popular variety because it actually triggers the release of endorphins into the bloodstream, which are the body's natural pain relievers. One may think that because your patient has fibromyalgia and because they already are highly sensitive that they may want to stay away from acupuncture. However, just as I stated before, these can naturally release endorphins into the bloodstream and act as pain relievers for individuals with fibromyalgia. Hello everyone, myself Monique Chavers. On behalf of Susan Jimenez, we would like to thank you for watching. We have presented musculoskeletal disorders and osteoarthritis and fibromyalgia. Please leave your questions in the discussion and we'll be sure to have answers for you. Again, we thank you for watching this presentation. Goodbye.